This video covers fluid and blood resuscitation in traumatic shock, a critical topic in emergency medicine. Please refer to the listed reference materials for more in-depth study. Severe hemorrhage is associated with high mortality rates, accounting for nearly 50% of deaths within 24 hours of injury. The mission is to restore tissue perfusion and oxygenation while limiting further volume loss. Traumatic shock triggers a systemic response known as the triad of hypoxia: tissue hypoxia, systemic inflammation, and coagulation activation. This results in impaired oxidative metabolism and oxygen debt. Oxygen debt accumulates when oxygen delivery can no longer meet tissue demand. Prolonged debt leads to irreversible organ damage and is strongly linked to mortality and multiple organ failure. Lactate and base deficit are used to estimate its severity. Resuscitation must address the lethal triad of trauma: acidosis, hypothermia, and coagulopathy. Acidosis impairs the heart and clotting, hypothermia inhibits clotting enzymes, and excessive clear fluid worsens coagulopathy. Trauma-induced coagulopathy, or TIC, occurs independently of fluid administration due to massive tissue injury and shock, which activates protein C. This leads to hyperfibrinolysis. Early intervention requires plasma and antifibrinolytics like TXA within 1 hour. The traditional 3-to-1 rule for crystalloid resuscitation is no longer favored. Excessive crystalloids are linked to risks like ARDS and worsened coagulopathy. Limit initial crystalloids to 1 to 2 liters before moving to blood products. This table shows the theoretical volemic effect of 1 L of fluid administration on fluid compartments. Hemostatic hypotensive resuscitation, or permissive hypotension, aims to maintain a lower blood pressure, SBP 80 to 90 millimeters of mercury, until bleeding is controlled. However, this is contraindicated in patients with brain injury, myocardial disease, or cerebral ischemia. Balanced blood component therapy uses a massive transfusion protocol, typically in a 1:1 ratio of packed red blood cells, fresh frozen plasma, and platelets. This mimics whole blood, prevents dilution of clotting factors, and should include TXA within 3 hours of injury. Resuscitation endpoints go beyond traditional vitals. They include the normalization of lactate and base deficit, urine output greater than 0.5 milliliter per kilogram per hour, and target tissue oxygen saturation of 75 to 80%. In summary, fluids cannot replace early source control through surgery or angioembolization. All resuscitative fluids must be warmed to protect the coagulation cascade. Resuscitation is a dynamic process aiming to stop the bleeding and clear the oxygen debt as quickly as possible. Thank you for watching this video. Please continue to study, reflect, and improve your knowledge.